Good morning, guys. Occlusion is a very vast subject. So, in this lecture, just giving you a brief introduction to the dental occlusion. Occlusion is defined as the way the teeth meet when the lower jaw, that is mandible, and the upper jaw, that is maxilla, they come together. Actually, maxilla is a fixed entity. Mandible moves. So we can say that when the mandible it comes closer or comes in contact with the or comes together with the maxilla. It is how the teeth they contact in any type of functional relationship. Malocclusion of the teeth is malalignment problem, which can lead to serious oral health complications. Father of the modern orthodontics, Edward Engel, he classified malocclusions as class 1, class 2, and class 3 malocclusions. We are not going at the moment in the details of those. All of us are familiar with how the class 1 is, how the class 2 is, and how the class 3 is, depending upon the molar relationship and incisal relationship. Occlusion is the contact of opposing surface of teeth of two jaws. And centric relation is untranslated hinge position of the mandible to maxilla. Hinge position means just opening and closing, just like the hinge of a door, opening and closing. Centric occlusion, it is the occlusion of teeth as the mandible closes in centric relation. And this is the reference position from which all the horizontal positions, they are eccentric. Disocclusion, or in some of the papers you will see disclusion, so it is the same thing. It is contacting of the designated groups of teeth in order to disallow contacts of any other groups of the teeth. Means during lateral movement, the orbiting is the non-working condyle. It revolves in orbit around the rotational center of the opposite, that is rotating, which is working side condyle. During right lateral movement, right condyle would be the working or rotating condyle, whereas left would be the orbiting or non-working condyle, and vice versa. Like if we will take the other side as the working, then the respective other side is going to be the non-working or orbiting condyle. Disocclusion in the anterior guidance. And what is going to happen? There will be posterior disocclusion. When we bring our incisors together, our posterior teeth, they get disoccluded. And in canine guidance or cuspid rise, only canines, they are in contact, rest of the dentition is going to be out of occlusion. In group function, which is another way of normal dentition, from canine all the way up to the posterior teeth on one side, that is the working side, teeth will be in contact, and other teeth or the other side, which is the non-working side, teeth will be out of contact, as well as anterior teeth will be out of contact. That is again disocclusion. Disocclusion in canine guidance. So what is going to happen? Rest of the dentition is disoccluded, and in group function, non-working side and anterior teeth, they will be out of occlusion or in disocclusion. The side on which your mandible is moving, that is known as rotating path or the working side. Rotating side or rotating path condyle. Well, if we look at the teeth, keep in mind that the teeth, they have cusps, and if we say that this is the buccal side, this is the lingual side, and the buccal side. So this is the buccal cusp. Buccal cusp has two inclines in respect of buccolingual situation. This is the buccal incline of the buccal cusp of the upper molar. This is the lingual incline of the buccal cusp of the upper molar. This is the buccal incline of the lingual cusp or palatal cusp of the upper molar, and this is the lingual incline of the lingual cusp of the upper molar. Similarly, all these teeth, they have, like in buccal lingual situation, the cusps, buccal cusps and lingual cusps. So the buccal cusp, they will be having two inclines, a lingual incline and a buccal incline. Similarly, on the buccal cusp, it is going to have two inclines, one lingual incline and one buccal incline. Just letting you know about this. So if there will be interferences when you are moving your jaw on one side, say for instance, in our case, we are moving the jaw on this side, which is our left hand side and patient's right hand side. So these are the inclines which could be in contact, where you can find the interferences. This is going to be upper buccal cusps lingual incline and lower lingual cusps buccal incline. Similarly, on the balancing side, what we will see, the interferences will be on the upper lingual cusps buccal incline and lower buccal cusps lingual incline. Upper lingual cusps buccal incline and lower buccal cusps lingual incline on the balancing side. Non-working side is also known as balancing side, and the condyle on this side, we call it orbiting condyle or the orbital path condyle. Well, this is the working condyle and this is the non-working condyle or the orbiting path condyle. It does not mean that the non-working condyle is not moving. It even works more. It has to translate. It has to come out of the fossa and then it has to go over the condylar eminence, and then it will be, or articular eminence, and then it will be moving in the, or it will be rotating in the mediotrusion. Whereas the working side condyle will be staying inside the fossa and will be just rotating. Certain terms which we will be using in our lecture: maximum intercuspation, it means most closed complete interdigitation of the mandibular and maxillary teeth irrespective of the condyle centricity. Teeth are in maximum intercuspation irrespective of the condyles present in the centric relation or not, because in most of the cases, from the centric relation to the centric occlusion, there will be a shift, and when teeth they acquire the maximum intercuspation, the condyles usually they lose their centricity. Protrusion, forward movement of mandible. Retrusion, backward movement of the mandible. Transtrusion means total lateral translation or side shift of the mandible. Mediotrusion is the lateral movement towards midline of the head of orbiting or non-working condyle. Laterotrusion is the lateral movement away from midline of working condyle. Surtrusion is the upward movement of working condyle from its centric position. Detrusion is the downward movement of either condyle from its centric position. Hinge axis is the imaginary line connecting rotational center of one condyle and around which mandible makes opening and closing rotational movement. Ideal occlusion. An ideal occlusion should provide comfort and function in a predictable way. If we look at the ideal occlusion at the tooth level or teeth level, so what is going to happen over there? Cusp tip to fossa or cusp to the marginal ridge contact. There should not be any relationship of the tooth or the cuspal tip on any incline. If there will be an incline, it is not going to be a stable relationship. Jaw will move in order to attain the maximum intercuspation. Ideal occlusion at the articulatory system level means there should be posterior stability, anterior guidance, lack of posterior interferences when there will be eccentric movements like canine guidance or group function or protrusive guidance. Ideal occlusion at the patient level means patient is feeling comfortable. They are comfortable, they have adapted to their normal position of the teeth. Anterior guidance. In lateral excursion of the mandible, working side contacts preferably on the canines means canine guidance, and it will disocclude or separate the non-working teeth instantaneously. In protrusive excursions, anterior teeth they contact with and they will disocclude the posterior teeth. This is the protrusive guidance, this is the canine guidance. All other teeth are disoccluded. Posterior stability. Enough posterior teeth in each arch with solid and stable contacts in appropriate positions to evenly distribute loads and to allow the mandible to close in a reproducible centric occlusion. Ideally, there should not be any shift from centric relation to centric occlusion. At the same spot where we are getting the centric relation without any movement further, only hinge movement will occur and teeth should be in contact. That is ideal situation. But as I told you, unfortunately, in most of the individuals, we do not get that. There will be a shift from centric relation to centric occlusion. Posterior teeth, they contact more heavily than the anterior teeth. And that is going to be enhanced in case if a person is having taller cusps and deeper fossa. Maintains the teeth position, centric occlusion or the intercuspal position is easily reproduced, increased masticatory functioning is going to be achieved in case if there is an ideal occlusion. And there should be signs of lack of the posterior, like if there are signs of lack of posterior stability, so what is going to happen? There should be posterior stability. There should be posterior stability. In case if there are signs of lack of posterior stability, what we are going to see? There will be drifting of the teeth, phreamitis, fractured restorations, mobility of the teeth, and wear and tear of the occlusal surfaces and restorations. Phreamitis is a situation when a person closes their jaws and teeth are in contact and you just push the teeth from the buccal side, feel it, and you can feel the movement. That is that the teeth are mobile. That is phreamitis. Lack of posterior stability, we can see over here, the signs are evident. We have fractured teeth, even wear and tear of the teeth, we have fractured restorations, etc., etc. There should be absence of posterior interferences in case if we are going to have the ideal occlusion. There must not be any posterior. This is the non-working side, and non-working side interferences are even more deleterious. Well, there should be centric occlusion is achieved at the centric relation position. As I told you, there is not going to be any shift. Occlusal loads are axially transmitted through the teeth. Means all the forces which are being directed on the occlusal surface of the tooth, they should be having a resultant vector, and resultant vector should be going through the long axis of the tooth. Organization of occlusion. There are three recognized concepts that describe how teeth should contact in various mandibular positions. Bilateral balanced occlusion, unilateral balanced occlusion, which is also known as group function, mutually protected occlusion, that is the canine guidance or canine protected or cuspid rise occlusion. Bilateral balanced occlusion, that is achieved in complete dentures or long span removable partial dentures. Group function. Group function means on one side, that is the working side, teeth will be in contact, whereas On the non-working side, there should not be any interference, there should not be any contact of teeth. In bilateral balanced occlusion, teeth will remain in contact in all eccentric movements. And we cannot achieve this in fixed prosthodontics. In fixed prosthodontics, most commonly we try to achieve the group function. Mutually protected occlusion or canine protected occlusion. That is an ideal situation in natural dentition. Anterior teeth, they overlap and it prevents the upper anterior teeth, they overlap the lower anterior teeth. And that prevents the posterior teeth from making any contact on either the working or the non-working sides during mandibular excursions. Anterior teeth, they bear all the load and the posterior teeth are disoccluded in the excursive movements. So, posterior teeth are going to be protected in this way. In centric occlusion, posterior teeth, they direct forces through their long axis and anterior teeth are slightly in occlusion or they would be out of occlusion. They are not going to be in contact depending upon the situation. Hence, the anterior teeth are protected. That is why it's called mutually protected occlusion. Guidance. It describes the influenced path the mandible takes as a result of the contacting surfaces of the teeth. Depending on the contact and shape of the teeth, they should be in harmony. Protrusive guidance, which I told you earlier as well, it influences the path the mandible takes as a result of a forward thrust. Lateral guidance, canine guidance, it describes the way in which lateral excursions are affected by tooth-to-tooth contacts involving the canine teeth, only resulting in disclusion of the posterior teeth. Group function, when lateral excursions are guided by more than one tooth other than the canines on the working side, and non-working side is out of occlusion. Henhouse Quint, it says, by modifying the following 5 factors, a scheme of occlusion can be developed that will suit a particular patient best. But incisal guidance is the most important, number 1. And condylar guidance cannot be changed. Condylar guidance we get from the patient when we are recording their protrusive records. And then we adjust the articulators according to that, depending upon the, it is based upon the Henhouse formula, L is equal to H by 8. Anterior guidance. Anterior guidance in dental occlusion refers to the way the upper and lower front teeth, they interact during jaw movement, particularly when closing the mouth from the fully open position. It's a crucial aspect of occlusion as it determines how the teeth come into contact and guide the jaw into a stable as well as functional position. Here we can see the guiding inclines or GIs of the maxillary teeth are the surfaces which are responsible for the characteristic of anterior guidance. Anterior guidance. Guidance produced by the teeth themselves and not the temporomandibular joint can be on any tooth. The influence of contacting surfaces of anterior teeth on mandibular movement. Like in normal condition, upper teeth, they overlap the lower anterior teeth, and in such a way that it should not be more than half of the overlap. Like they should not be overlapping half of their crowns. The influence of contacting surfaces of the guide plane and anterior guide table on the articulator movement. The fabrication of a relationship of the anterior teeth preventing the posterior tooth contact in all eccentric mandibular movement. Posterior guidance. Posterior guidance in dental occlusion pertains to the interaction between the back teeth or posterior teeth during jaw movement, particularly in lateral and protrusive movements. It involves the way the cusps and surfaces of the upper and lower molars and premolars guide the jaw into a stable position during chewing and other functional movement. These are the movements, and we have already discussed about these inclines and the the way they are going to be in contact. In the laterotrusive movement and in the mediotrusive movement means on the working side. And non-working side, this is the working side, this is the non-working side. Then the retrusive movement and protrusive movement. And these are the surfaces of maxillary and mandibular first molars, which will be in contact during all these movements. Effect of craniomandibular joint anatomy on mandibular movement. Stott describes condylar factors as determinants of occlusal morphology and effect on acceptable cusp height and fossa depth and allowable ridge and groove direction of teeth, which are known as posterior determinants of the occlusion. And these are side shift, path of rotating condyle, intercondylar distance, and path of orbiting condyle. Well, posterior determinants, the angle of the articular eminence. We can see like over here, number 1 is quite flat, number 2 is average, and number 3 is quite steep. When the angle of the articular eminence is quite steep, then the cusps are going to be taller. And when it is going to be flat, then the cusps are going to be flatter or smaller. Number 2 is the anatomy of the medial walls of the mandibular fossae. Number 1 is greater than average, means in this case there is going to be more side shift. Side shift is that movement which occurs before any other movement going to occur, as the mandible is going to take some movement or is going to move. Number 2 is the average, and number 3 is minimal side shift. It all depends upon individual to individual and their anatomy. Effect of occlusion on, yes, keep one thing in mind: when there will be greater than average immediate side shift, then the cusps are going to be of shorter size, and definitely the fossae are going to be shallower. But if it is minimal, then we can give them taller cusp and deeper fossae. Effect of occlusion on mandibular movement. The factors within dentation which influences the mandibular movement, they are known as anterior determinants of occlusion, and these are occlusal plane, curve of spee, facial position of the teeth, vertical and horizontal overlap of the anterior teeth. We will discuss about these two things. Vertical and horizontal overlap of anterior teeth. Greater the vertical height, greater will be the cusp height. Means if there is deep overbite, then we can have taller cusps and we can have deeper fossae, because there is more separation of posterior teeth in eccentric movement. But in case if there is greater overlap, means horizontal overlap, means there is more overjet, then the cuspal height is going to be shorter and fossae are going to be shallower. Protrusive incisal path. The track of the incisal edges of the mandibular teeth from maximum intercuspation to edge occlusion, from here to here. The angle which is formed by the protrusive incisal path and the horizontal reference plane, that is the protrusive incisal path inclination or protrusive incisal path angle. This is between 50 to 70 degrees and is often 5 to 10 degrees steeper than the sagittal condylar guidance. Incisal guide angle. The angle formed with the horizontal plane of occlusion and a line in the sagittal plane between the incisal edges of the maxillary and mandibular central incisors when the teeth are in maximum intercuspation. The angle formed in the sagittal plane between the horizontal plane and the slope of the incisal guide table. On a semi-adjustable articulator, the incisal guide table, it represents a mechanical equivalent of the horizontal and vertical overlap of the anterior teeth. Importance of this anterior guidance: opening and closing of the mandible. We know that it is a simply rotation of the condyles in the articular fossa. And when there is protrusion, so what is going to happen? There will be separation of the posterior teeth as the teeth will anterior teeth will acquire the edge-to-edge position. Importance of this anterior guidance. Anterior guidance is linked to the combination of horizontal and vertical overlap of the anterior teeth and can affect the occlusal surface morphology of the posterior teeth. Now, say for instance, anterior guidance can be made steeper. You can play with the anterior guidance, and that is going to affect the anatomy of the posterior teeth. Anterior guidance can be made steeper by either increasing the vertical overlap, means increasing the overbite. Here we can see it is not too much of the overbite. Here we have increased the overbite. Or by reducing the horizontal overlap from C to A. Here we can see there is a lot of overjet, and here it is minimal overjet. So you can even reduce the overjet while you are making a prosthesis. Anterior guidance can be made shallow by either decreasing the overbite, which is this one, from B to A. Here we can see there is more deep overbite, or there is deeper overbite, and here it is shallow overbite. So, or you can increase the overjet from A to C. Here the overjet is minimal, and here we have increased or enhanced the overjet in this situation. So influence of the anterior guidance on posterior tooth morphology, effect of overbite. Greater overbite produces more disocclusion, hence permits longer cusp heights. And less overbite, less disocclusion, shorter cusp height is going to be mandatory. In greater overjet, it necessitates shorter cuspal height, whereas the less overjet, it will allow for the long cuspal height. When the overjet is minimal, then we may have the longer cusp height. So in summary, greater anterior guidance allows posterior teeth to have longer cusp height, and a smaller anterior guidance requires posterior teeth to have shorter cusp height. By increasing the anterior guidance angle to compensate for inadequate or shallow condylar guidance, it is possible to increase the cusp height of the posterior teeth. Similarly, increasing the anterior guidance will permit lengthening of the cusp that otherwise have to be shorter if a person is having pronounced immediate side shift. As I told you earlier, when there will be immediate side shift, then it is necessary to have the shorter cusp height, but we can play with it, because if they are looking unaesthetic, so we can increase that person's decrease that person's overjet and increase that person's overbite, and we can have taller cusps. So anterior guidance and mandibular movement. The anterior guidance between the maxillary and mandibular anterior teeth has a direct influence on the direction of the mandibular movement. Here we can see that is the protrusive movement in these arrows, steeper anterior guidance, and this is the condylar guidance. Here we have shallower anterior guidance, but they have same condylar guidance. The reduced clearance between the posterior teeth during protrusion in this situation, leading to the cuspal interferences and possible wear and tear. So if there will be shallower anterior guidance, then the cuspal height is going to be reduced. So over here we are done with this, and hopefully it's going to help you in solving your questions which will be coming on the anterior guidance in your exam. Thank you very much.